Ma'am, please start.
Yeah. Good evening, everybody. I'm Dr. Nandana Jasti, General Physician at Medicover Hospital. On behalf of Medicover Hospital, in association with Heartfulness Meditation and API, we are very proud to bring this virtual COVID education series. Today will be day 7 or topic 7, which is new to all of us in the sense with the numbers. Epidemic after a pandemic regarding in terms of mucormycosis outbreak. There's a lot more to learn and a lot more to exchange information and learn from the leaders in the field. I will not take much time. I will now ask Dr. Ghanshyam to introduce our panelist and the speaker. Over to Dr. Ghanshyam.
Thank you, Dr. Nandana. In continuation with the COVID education series that we have been having for the last couple of weeks, we will try and discuss a very, very important topic which has kind of troubled a lot of us, and created so much of morbidity and mortality in terms of both loss of life as well as disability. That is the incidence of mucormycosis and the rising numbers. To take us through, I invite Dr. Sampurna Ghosh, who is a consultant ENT surgeon at Medicover Hospitals. The brief lecture will be followed by a panel discussion, and it is indeed a great honor to have Dr. Professor Anuralok Chakravarti, who is a professor and head Department of Microbiology, PGIMR Chandigarh. Sir is one of the leading authorities as far as mycology is concerned in the country and the world. It's a great privilege to have Professor Chakravarti with us. And joining him in the panel, I invite Dr. Vishnu Rao, who is a consultant infectious disease specialist with Apollo Jubilee Hills Hospitals. Dr. Yash Javeri, a dear friend of mine, who is the head of critical care anesthesia, emergency medicine, Regency Healthcare, Lucknow. Dr. Ravicharan Palwai, again, who has seen a lot of cases of mucormycosis, along with Dr. Sampurna at Medicover Hospital. He is a senior consultant ENT surgeon at Medicover Hospitals. And to take us through, I also invite Dr. Rahul Agarwal, a dear friend and a senior consultant physician with Medicover Hospitals, who will be there with me moderating the session. Over to Dr. Sampurna. And lastly, Dr. Manish, who has been there with us since the start of the webinar, will be there in this series as well. Welcome, Manish.
Thank you, Ghanshyam. Thank you.
A very good afternoon, everybody. This is indeed an honor to speak on this topic, where especially Dr. Chakravarti, Vishnu sir, and our senior physicians are there. So the topic today is epidemic following pandemic mucormycosis. I would like to start with the thought process that why we are getting so many cases during the second wave. I will not say that first wave I didn't get cases. Yes, first wave also I operated on mucor patients, but the number was like 1 or 2 cases in a couple of months. Whereas now, if every ENT surgeon has been probably flooded with these cases, me and Ravicharan sir individually, daily 2-3 cases we have been operated. So I would like to share our experience and the database of Medicover Hospital, whichever we have done in last May and this part of the June. So starting with the basic classification of fungus, that it's not that we are only getting mucor, we are also getting the other fungus as well. Many of our cases came as mixed infection. So basically it is elaborated by the pathologist more than the microbiologist. So they will write that whether they're finding the aseptate hyphae or septate hyphae or both. Accordingly, we are making the treatment plan, and the choice of medication is being decided upon that. So this is just from a paper from Mediterranean Journal of Hematology. So because if you see the mucor cases before the pandemic, whatever cases we used to get, rarely, though rare, That used to be usually blood cancer patients or those who are on chemotherapy or severe diabetic on dialysis, this kind of cases. And in that, if you point out that what were the factors for getting opportunistic infection, not only mucor, the one very important factor, of course, is decreased cellular immunity. Another important is mucosal barrier injury. So I don't know in COVID what is happening, but definitely there is some kind of mucosal barrier injury which is starting from the very beginning of the nostril and the sinus mucosa, and maybe also in the nasopharynx. That may be one reason why the fungus is growing so fast in the sinus on the very first place. Because as you know that the fungus is part of the ecology. So we are, as a living human being, our body itself harvests a lot of bacteria and fungus, and it's there everywhere. So why do only the COVID patient is developing the infection? One of the major point must be the mucosal barrier injury, which is happening in the nose itself. The second part may be that the use of oxygen cannula, which is hitting somewhere, or the humid environment giving the moist oxygen, is favoring the fungus to stay back and giving a good medium to grow. The third factor may be the high ferritin level. As we all know that mucor grows well in a high ferritin level. The other factors may be the way the virus is attacking the pancreatic beta cell, and many people are coming with de novo diabetes. That is adding on all this burden. The last factor, I think the second wave COVID strain itself may be responsible, that how it is affecting the cellular immunity really bad compared to the first wave strain. So all this together is the reason of the surge, which causing havoc on the economy of the patient, and like the amphobic cost is so high. So more than treatment, now is the time that we have to think how we can really stop this. So this will definitely come in the panel. So I will directly go into our experience data, the facts. So previously the thought process was like that these are the patients you will get affected. Now we are getting simply no history of ketoacidosis, simple presence of diabetes, and presence of history of COVID plus minus steroid intake. So these people are getting affected. And what are the clinical features? So I would tell you here that our classical teaching, as during MS, what we have been taught, that mucor cases will come with lot of necrosis in the nasal mucosa, or the palate will become dark. So this kind of classical feature is rarely found in post-COVID mucor cases. Ravicharan sir will also agree. The reason being that we are detecting maybe in early stages. So I have found the most common symptom is facial pain. So pain around the maxillary region, around the jawbone, or unexplained headache, and also some kind of tooth pain. These have been my commonest findings observed in my patients, which is not nasal discharge, crusting, blocked nose. Very few patients mentioned about these things. Of course, the patient who came after quite a weeks of symptom neglected, not treated, they are complaining of bleeding from nose, etc. They are coming with loss of vision, blood vision, double vision, or complete ophthalmoplegia. But initial symptoms are usually pain in the face or in the headache. So yeah, headache is a very, very important point, because we know there is an entity called post-COVID headache. Sometimes the patients themselves believe that it is just because of the weakness, or physician also takes some time that, okay, it may go. But I have found that most of these unexplained headache patients, when we did MRI and when we did FACE and send the tissue for biopsy, mostly they came positive for mucor. And as soon as we started the mucor specific treatment, that headache came down. So what is our my diagnostic algorithm is, first I trust on the history and clinical suspicion the most, followed by radiological. I will go for MRI with contrast wherever the logistic is possible. If the creatinine is high, then I will go for simple MRI. But of course, I will include MRI, PNS, orbit, brain all together. The third factor will be microbiological, and the fourth will be histopathology. I would tell you that out of the 20 cases I have operated, in that only 2 cases KOH mount came positive. All the 18 cases KOH came negative, but the biopsy came positive for fungus. So biopsy, I do trust a lot on that. And even if everything comes negative, biopsy not getting the fungus, microbiology negative, still the pain is not reducing, unexplained rise of CRP, then I would prefer to go with the protocol of treating mucormycosis. So the clinical suspicion is the number one point I would stress upon. So is there a role of diagnostic endoscopy or not? Because many times I get patients from the periphery where somebody has done diagnostic endoscopy and given the report that doesn't look like fungus, there is no necrotic tissue. I would say that at this scenario, today's picture, I would say there is absolutely not much role of diagnostic endoscopy unless the case comes to you at very late stage. We do not expect to find anything other than little purulent discharge. Sometimes there was no purulent discharge. After opening the sinus with endoscope, we could find the fungus, or sometimes even perioperative finding was also looking like normal, but the biopsy came positive. So don't give much stress on diagnostic endoscopy or tissue or sample being collected in OPD. That comes negative most of the time. Coming to the radiology, already I spoke about that MRI will be the first preference. And not only that, what does it help by doing MRI with contrast, and how does fat suppressed MRI help us? I would like to say a few sentences on that. That whenever we want to know as a surgeon before debridement, we want a planning, right? That how much to remove. So doing a sinus surgery for mucor is completely different than doing regular face. So the face is functional endoscopic sinus surgery, wherein what is the name given functional is that we want to preserve the mucosa as far as possible. Whereas when we operate for mucor, we want to remove tissue as far as possible and as far as needed. Sometimes it is good to overdo, but it is not good to remove less tissue. So in that way, CT scan doesn't guide much, because in CT we can only see the bony outline, and if there is any definite breach in the lamina papyracea or skull base, we can see that. Whereas MRI gives us a pretty good idea that how much soft tissue involvement is there, especially when the involvement is going beyond the sinus, like in the orbit or in the pterygopalatine fossa or in the infratemporal fossa, nothing like MRI. Talking about the fat suppressed, I would like to say this works excellent to get an idea about the orbital spread. Many a times I have seen the patient comes with full proptosis, ptosis or ophthalmoplegia, but the MRI is not showing direct invasion of the fungus into the orbit, whereas there may be minimal eye symptom, but the fungus has directly gone into the orbit. So depending on that, we need to decide that is it okay just to do our orbital decompression, or do we have to go inside up to the medial rectus? Or if the orbit is surrounded by fungus more than 180 degree, then there is not much role of doing it endoscopically. We have to do the orbital exenteration. So there comes the role of fat suppressed MRI, wherein the fat in the orbit will be suppressed. So it will look all black. In that area, if anything gray or whitish is seen, it is very easy for the surgeon to pick up that that is nothing but the fungus. So another thing I have started doing recently, that a few cases, especially young patients and those who are not diabetic, even though I am suspecting that it is mucor, but somehow the biopsy is coming negative each time. So I do send for, there is a typing mistake, inconclusive results, what I wanted to write in the heading. So in these cases, I'm sending the tissue for PCR for mucor, which is a pretty sensitive test. If that comes negative, I will be little assured. And also when the biopsy comes negative, I'm sending some blood tests like, beta glucan, galactoman. And so in case aspergillus, which could not be picked up by the lab people, if these results are high, so I can treat like aspergillus. Coming to a few scans, so this is a CT-PNS. You can see there is breach in the medial orbital wall. There is a breach near the orbital apex. So this guy came to me with loss of color vision, and just blurring of vision started, and his vision was regained after the surgery. This is another patient scan. So this is the sinusitis part, which is very evident, and interesting findings are in the lungs. This guy, I could not isolate fungus from repeated biopsy. It kept on coming negative, but endoscopic findings were positive for mucor. There were a lot of necrosis. So the septum was already absorbed because of the pathology. So I did extensive sinus surgery, and we are treating like fungal sinusitis only, and seeing the lung lesion, which I don't know, probably aspergillus or look like fungal lesion. So he's still under treatment, but he has come out of the risky part. I would say that the survival, the question was whether he will survive or not. From that part, we could take him out. Management protocol that so whenever I gave this kind of patients, we all first try to start antifungal as a empirical therapy. Physicians will also agree that they start to give the antifungal, and definitely then I will read the MRI scan, possibly with the radiologist, because sometimes they give more input than what we see, and then I try to plan the surgery ASAP. So there is no delay in anything. Antifungal and the surgical debridement both should go hand in hand, because both are equally important. Unless we reduce the load of the fungus, the amphoby requirement will still be very, very high. So I usually we involve a lot of specialists in the team. Whenever we treat mucor cases, I definitely give a referral to one of my physician friend or endocrinologist. And then when I see if the creatinine is rising, I will of course involve the nephrologist. Maxillofacial and ophthalmologist optional. Wherever the involvement is there, I do that. Scope of endoscopic sinus surgery. Yeah, coming to that part, that what we actually do in the endoscopic surgery, until what level we can go. So I have made this a routine practice of mine, that whenever I do endoscopic surgery for suspected fungal disease, I definitely do a medial maxillectomy. So like medial maxillectomy is removing the medial wall of maxilla along with the inferior turbinate, everything endoscopically. The reason behind it, there are two reasons. One is, unless we open the maxilla pretty big, we cannot see the lateral wall floor of the maxilla. So in normal phase, we make small opening in the maxilla. So when you want to see all the walls of a 3D structure, you really have to have a bigger access. By doing endoscopic medial maxillectomy, I can inspect all the walls so that there is no hidden focus of the fungus sitting out there, and I can have an idea about how the bone is looking. If the bone is not bleeding, or it is discolored, it looks like a dead bone, I will remove the posterior wall of maxilla as far as possible. I also remove the orbital floor endoscopically, but I call my maxillofacial colleague when I see floor of the maxilla is looking black or unhealthy. That time I call the maxillofacial people, and we both together do the maxillectomy. How much is required? There is no fixed rule or standard protocol for maxillectomy. However, whatever area looks unhealthy, remove that bone. So that is it. Total ethmoidectomy, sphenoidectomy is done in most of the cases. Of course, frontal clearance is done, and wherever there is orbital edema or inflammatory changes around the orbital muscles, I do medial orbital wall removal and orbital floor clearance as well. In a couple of cases, I have done optic nerve decompression also endoscopically. By doing that, I could save the vision and eyeball for that patient. Yes, can we go beyond the sinus endoscopically? Yes, pterygopalatine fossa is pretty well approachable through endoscope as well as infratemporal fossa. We can do that. So we get some structures like maxillary artery, which can bleed. We get the nerves, foramen rotundum, V2, all these nerves. Pterygoid muscle, I have debrided that as well in one patient. the mouth opening was becoming less, even though the sinus clearance was pretty good. But the main complaint was her mouth opening was getting less, and she was having tremendous pain around the cheek and this joint area. So after I removed the pterygoid muscle, I drilled up to the pterygoid bone, that pain came down. So up to this, we can reach endoscopically. Coming to few of the MRI, yeah. So this is one a patient who had the majority involvement in the maxillary sinus, and this guy, if you can see, the ethmoid and posterior ethmoid sphenoid is involved, which is pressing on the orbital content. These eye we could, and you can make out the proptosis. So after doing the medial orbital decompression, the eye could be saved. How does the fungus look endoscopically? As I told you, many patients have nothing abnormal to look on endoscope, but few have a very classical look. So this is one of the look. This is the choana, and this is inside the maxilla. As I told you that I do medial maxillectomy. So what you are seeing is head-on posterior maxillary wall, and the fungus is nicely sitting here. Okay, how the fungus, yeah. Another picture, if this picture, I don't know how well it is visible. So this is one interesting finding. Look, the mucosa looks healthy. Nice pinkish mucosa, nicely bleeding. But once I remove the mucosa from the bone, you can see this yellow, little yellow spots. So these are the fungus. So it is nicely hidden between the mucosa and bone. So how it will look endoscopically may be very different, varied presentation from patient to patient. This lady's MRI also, if you see, look, this is the MRI. She had only little mucosal thickening in the sphenoid sinus. All the rest of the sinus, maxillary, ethmoid, frontal, everything was clear. But her complaint was some kind of excruciating eye pain. So that is why I decided to operate, and I found out in the sphenoid, in the bony part, the fungus is hiding. This is just an example that how much we can go through endoscope. So this is after frontal clearance. When the frontal is nicely cleaned, we can see this glow endoscopically. This is after the maxillary clearance, and this picture is before surgery. This is the proptosis. After surgery, the eye swelling, eye pain reduced. Coming to this interesting case, this sorry, yeah. So this guy came with right. So this guy came with a complete ptosis, ophthalmoplegia, proptosis, and the lesion was here. So in the MRI, this is very suggestive. Look, the contrast has been taken up nicely by the turbinate and all, but this area is black. So the area which doesn't take the stain means that is gone. The vascularity is gone, that is necros, and that is what we have to remove. And this is what I have done. You can see my probe is pointing towards the optic nerve. This is the sphenoid sinus. This is the optic canal in the sphenoid, and this is posterior ethmoid. So I decompress the optic nerve, and his vision has improved. After that, he is getting now intraorbital ampho-B. So whatever the ophthalmologist recommend accordingly, I am giving that, and till now he is doing good. This I would like to say, this is a complication. I would say that is a. Okay, anyway. So what I wanted to show you here is I was doing a frontal clearance, and this was also a mucormycosis. Many of these cases, the bone becomes so fragile that it's easily, it can be punctured with simple instrument, which otherwise in face we don't get. So while doing the frontal clearance, I was doing with a 70-degree scope, and near the attachment of middle turbinate, CSF leak started from here. So as a surgeon, if we can identify, it's not a big deal. So I did repair also, and it has closed now. Again, another case, this guy, yeah. So this lady presented with cleval involvement of the sphenoid. No other sinus was involved. And again, I did exposure like pituitary surgery. Bilateral sphenoid was widely open, and I took out all the mucosa. And then I found out this thing. So these are the fungus hidden in the bony part. Open approach, when there is a limitation of endoscopic surgery, definitely, so we can't arrogantly say everything we can do. So we need open approaches. So whenever the maxilla is involved, zygoma bone is involved, or the masticator space is swollen up, of course we have to do the open approach, either by Weber-Ferguson incision from here or from intraorally. Brain involvement, we definitely have to do open approach. Orbital involvement, exenteration is required sometime. So this is a case which, so this kind of presentation, this is not doable by endoscopic, definitely. Look at the soft tissue involvement along the cheek wall, parotid region, everything. It was so much inflamed and involved that the patient had facial palsy in the very presentation. And this palate was completely black. So these kind of cases definitely need open approach. Taking out the eyeball and taking care of the maxilla up to the masseteric place. Now coming to this case, sir, am I audible? Yeah.
Yes.
You're audible.
You are audible.
Anushyam sir is.
Yeah, you're audible. We can see it. Please continue. अभी आप म्यूट पे हो संपूर्ण. You have to unmute. Dr. Sampurna, please unmute.
Host, can you unmute her?
I'm just trying, yeah. She's unmuted.
Now you are unmuted, please. Sampurna, please continue.
Sir, you could not hear up to this?
No, we have heard everything. Thank you.
Okay, so this is the, again I'm talking about the open approach. Okay, another 5 minutes I will take, sir. So in this case, first I did endoscopic sinus surgery. I cleared the whole ethmoid, maxilla, everything. But then again, the pain was not reducing. And in the repeat CT scan, I found out this is the pterygoid flesh, which is eaten up. So you can see this moth-eaten appearance. So I decided to go for open approach. Yes, so this is the picture of the patient that this swelling was not reducing somehow. So we did take out this part of the maxilla and part of the zygoma, and right side you can see the post-op picture. This case I did last year and he's doing well. So usually I will do follow-up for 2 to 3 months minimum. I don't celebrate before that. After 3 months, I can say, okay, you are disease-free and whatever I've done that has worked well. This is an example of bilateral maxillectomy. This case, the sinus involvement was minimum, but the fungus was growing along the floor of the maxilla. So both the sided maxilla and all the tooth were removed and she's doing well. This is an example of orbital exenteration, and this guy developed this fungal abscess. So that was also taken care by our neurosurgeon, Dr. Srikant. But even though post-op 10-15 days he was doing well, he went home. After that, yesterday he called that he is not speaking and he is having convulsion and all. So my take-home message is intracranial extension is really, really bad. Even though during surgery or during hospital stage, patient may look well, but chance of survival is really less. So this is a post-op MRI after maxillectomy. This patient is doing well. This whole part, this area has been taken out. This is the mucosal flap which is surviving, but there is a gap in the suture line here. So he's out of infection now. So we are going to do the reconstruction part with the maxillofacial surgeon. So there are many varieties of amphoby. I will not go into that. Physician sirs and Vishnu sir may cover that. But I will tell that what is the difficulty we are finding when we are giving amphoby. Until recently, the liposomal stock was coming from government and that did not cause much of reaction. But now as we are getting this emulsion variety, that is causing a lot of thrombophlebitis. So many of my patients, we had to advise for EJV line because one channel is going, it is destroyed in one day and it's so painful. Otherwise, definitely hypokalemia, a lot of hypokalemia is happening, rest creatinine. Other than liposomal, all other varieties, deoxycholate, lipid complex, emulsion, all are causing nephrotoxicity. But I have seen after stopping, it is coming back to normal. So it's not probably irreversible, it is probably reversible. And there are other drugs, posaconazole, and for aspergillus, some doctors are giving voriconazole, itraconazole also. I don't have much experience on isobuconazole, but I do give posaconazole to all my patients, and I'm happy with that result. And even if there is mixed infection, I probably would like to continue with amphobi and posaconazole because it has coverage for both the fungus. So this is my follow-up protocol that I do repeat CRP quite a lot. This is a very sensitive marker. Once the CRP is down and it is staying stable, then only I will think that antifungal can be stopped or not. Of course, electrolyte and RFT is repeated every day or alternative day if the patient is on amphobi. I do repeat endoscopy on day 5, day 10. After that, depending on the patient's progress, repeat debridement is very, very important. Tracking these patients are very important. One surgery is not good enough. Whenever there is something remaining in the scan, you take to OT and we do repeat debridement. And sometimes I do repeat the MRI, repeat the CT scan as per the patient's requirement. So that is our experience that from May to today, there were 53 cases in Medicover High-Tech City. In that, this percent, 30 patients, this is the absolute number, the blue one, and this is the percentage. So 30 patients had the history of diabetic, which accounts for 56%. 44 patients had history of steroid. That means 83% of patients had history of steroid. In these 53, everybody didn't go for surgery. Some were not operable, some did not give consent. So from 53, we operated 35 cases. I would like to share my personal experience now. I have done 20 cases since May. In that, 16 cases came positive for fungus. 4 fungus was not detected. It was either odontogenic or simple bacterial, which flourished after the COVID infection. 8 of my patients needed redebridement. So among 28 cases needed redebridement. Sometimes it needed 2-3 times surgery also. And in 6 cases, I had to go for open approach along with the maxillofacial surgeon. So of course, prevention topic, the last thing, I think already we have started using the steroid much more cautiously and judiciously. And I think we should also reduce use of broad spectrum antibiotic like doxycycline for each case. I don't know, probably it is not required. Or piptaz, whenever patient gets admitted, we give piptaz, magnexport. We have to think on that line also, that is it what is damaging the mucosal barrier? Is it altering our microbiological flora? Why the opportunistic infection is growing so much? And we should probably teach our paramedical team who spend more time with the patient to pick up the early symptoms. Sometimes patient, when the doctor comes for round, it may be just for 5 minutes. They are more comfortable with the nurses. So if anybody complains of tooth pain, eye pain, any swelling, then you should give a ENT referral or you should tell the primary physician about that. And maybe for the discharge summary, whoever receives steroid or diabetic, we should add a short column in that what are the danger sign of fungal sinusitis. If you get, you come back to hospital for ENT consultation. Thank you.
Thank you very much, Dr. Sampurna. I'm Dr. Rahul Agrawal. I'm the physician here in Medicover. That was very interesting and very elaborate in a very short period of time. And of course, you have been doing very great job along with Dr. Ravicharan sir, who is also an excellent ENT surgeon. My first question goes to Dr. Chakravarti. Sir, as leading mycologist, what is your take on the risk factors that you have seen thus far that has really caused concern? And is there any way that an immunocompetent patient might still have a mucormycosis? And when are we going to say more alerted when an immunocompetent comes to you and then this patient might have a mucormycosis? We have been seeing a case reports of dental extraction followed by mucormycosis. So your take on this, sir?
See, the thing is that I'm going to tell it's not the COVID era when we started looking into mucormycosis. We are seeing mucormycosis since long time. And these cases which we used to see much more in case of the diabetic patients, uncontrolled diabetes. And India has got a distinct position in case of mucormycosis because we have already reported that Indian case numbers were around 70 times to the Western world in this scenario. Now, why those people used to get mucormycosis? First thing is that mucor is very much in our environment. We had done 2 studies which we have published, which have shown the spore counts both in the indoor as well as outdoor. The spores are very high in number. So whenever a patient who is uncontrolled diabetes make the people susceptible because there are 2 factors which are very important in mucor is the innate immunity. And this innate immunity is both by macrophage and neutrophil. Any spore comes inside, first it is the macrophage tries to engulf and kill it. If by chance it fails, then whenever the hyphae produced from the spore, then macrophage cannot handle it. Then it is the neutrophil which has to handle this situation. Now in diabetes, both macrophage and neutrophil gets disturbed. Macrophage gets disturbed by their phagolysosomal fusion, which is the mechanism of activity of macrophage. And neutrophil gets disturbed because the neutrophil chemotactic factor is going down. So we had a very distinct position in case of mucormycosis earlier also. And even in case of India, what we have seen in our study, that 23% of the patient who came first with mucormycosis and then you check your blood sugar, it found that fasting blood sugar is more than 300. So generally, we all love sweets and we are very scared of doing our blood sugar test. And even when you are diabetic, I'm not saying that general public, forget about general public, even in your doctors community, I have seen a lot of those doctors, those who are diabetic, they also cannot maintain. Possibly I'm not diabetic, but the diabetics possibly really have some craving for the sweets. That might be one of the important issues which comes. Now, in case of COVID-associated mucormycosis, if you ask me what are the risk factors, of course, we had a study which is in 2020, which we conducted, and which is now online in emerging infectious disease. And this is a 16-center study in India. That study had brought out 2 major factors, which is very clearly, one is the diabetic factor, second is the steroid factor, which are brought into. Now, you may say, yes, 2020, there were cases. Yes, we have shown 2 times of the cases compared to 2019. That means there is an increase of 2 times is there. But the 2021 is phenomenal. I would say that whether you have seen on the government, the portal, already more than 32,000 cases have been detected in India. And these have been detected over a month. It's a mind-boggling figure in case of mucormycosis. Now, why it happened? Why in case of this, there are so many theories people try to bring in. But I would say that we are all scientific person. We like to go by evidence. At least what are the evidences in front of us? First evidence is that diabetic patient is there. What happened during this second wave, so many patients came in the hospitals. Doctors were looking the patients in the corridor, even in the pavement. These have been shown in so much of the TV. And they were trying to save the patient about their life. Means they are looking into their oxygen, whether they are getting the oxygen properly or not. So how many of you have done really the glycemic control in those patients? Nobody has checked the blood sugar. So when now the cases have come, I have never heard such blood sugar level, more than 800 blood sugar. Have you heard it? We have seen a number of patients like that. So this is one major factor which happened. Second factor happened is the steroid. Steroid, what it happened is that because of the oxygen crisis, people were trying to compensate the oxygen which is not there by increasing the dose of steroid. What we have found that in certain centers, they have gone up to 30 milligram dexamethasone. Generally, it is said that 6 milligram dexa should be given 5 to 10 days. But if you give 30 milligram, means 5 times. So it's going to the roof. Blood sugar is going to the roof. That happened. And as I've said, this steroid also have very important role in case of innate immunity. So steroid had played the role second. Third role, about the COVID, we are not still very clear, because how much is the COVID playing the role? But one thing, possibly you have already seen those two papers which had come. One is from Stanford, another is from New York. Both this study has been supported by NIH. It convincingly shown in autopsy that COVID-19 damages the beta cell pancreas. If there is a damage to the beta cell pancreas, there would be further increase in blood sugar. Now we also, Madam Ghosh already mentioned about the ferritin issue. That issue is also very important because iron metabolism gets disturbed, ferritin content in the cell increases, and because of that, oxygen-free radicals come, it damages the cell, iron comes in the circulation, which helps. Mucorals love iron because it has got CD4 on the surface, it takes up the iron. So this is one issue which is there. And whenever you see this hyperglycemia, we did see that there is a hyperferritemic state, or ferritin goes much higher. Next is, of course, the COVID stress itself increases the cortisol. Cortisol is also one of the stress hormone which you all know. And this cortisol also increases the blood sugar. So this all circle going into it. But I am still not convinced that, am I looking to the whole elephant, or there is some portion of the elephant I am not seeing. That's why what we are doing a study now, we are looking into how much is the COVID causing disturbance directly to the mucor-specific immunity. That would be a very important issue which we are trying to look additionally. That is being, and fourth factor, of course, the environment. And this environment is having so much of the, you will not believe that when we are now collecting the samples from the patient's house and all those, they have prolific growth of mucor is there in their environment. So this is one important issue, but we don't get the infection because we have immunity. But when you have a vulnerable person, when there is the COVID is there, COVID causing stress, diabetes is there, all these factors mix together a patient vulnerable. So I'm not very surprised about this second wave, why so much unprecedented number of cases came. But I am still curious in few things which I have no answer. One is the COVID-19, how much it is damaging. Second factor is that whether these particular strains which we are now isolating, Rhizopus aeruginosus is the commonest isolate we are getting, whether this is more virulent. We are not very sure about it. Third factor, is there any other environmental factor? Of course, I am not going into those story of oxygen, humidifier, water, and some people say it is the steam inhalation. These are nothing going to do, because we have already studied all these issues and settled that there is no problem about this. But I'm not having dogma in case of environment. We are still looking trying to find out if there is any other factor which can be responsible. Sorry for a long answer to giving you a short question. I'm sorry in that sense.
Thank you so much, sir. It was really very, very informative. In fact, it should help a lot of us clinicians while we are dealing with such patients. My next question would be for Dr. Vishnu, which is carrying forward what Dr. Chakravarti said. So, that is there any role of a prophylactic way, or is there any role of initially trying to say evaluate a patient who comes to our OPD, which is that the case in our ER? We have a lot of cases who come a little late, and then they are obese, they are probably diabetics, because we have been seeing a lot of high sugars first time detected during our first encounter with the patient in the ER. Is it a need now that we start doing a CT PNS as a routine for high risk cases along with CT chest so that we can catch them young?
Yeah, Thank you that you brought up this question. Two things here. You asked about number one, prophylaxis. Number two, about the screening. See, first thing is this prophylaxis, it's a big no. It's 100% big no for any antifungal prophylaxis without any rationale. Because we need to, as Dr. Arunlok sir already said, that we need to understand the risk factors. Still, there are a lot of centers who pump steroids, like, there's a lot of areas where they give pulse dosing steroids and, addressing the diabetes in the early stage. These are the two primary things. The reason is that, for example, the mucor rates in our center, our naive mucor rate centers is very, very low. So if I have to prevent one mucor, I have to prophylax 1,000 or 1,500 people, which is absolutely not justifiable. If we start prophylaxing everybody, we try to start abusing them rather than addressing the true, underlying risk factor. So absolute no for a prophylaxis. And number two is about the screening. See, actually, we do this in our center, but now we 100% know that it's the diabetes and the increased dose of steroids are the risk factors. There is a role for screening. I think yes. What we do in our center is that those people who had prolonged ICU stay, who requires higher cumulative dose of steroids, somebody whose steroids are whose sugars are not under control despite involving endocrinologist, when they stay long, when they come out of the ICU, we are doing visual inspection of the sinuses involving the ENT and trying to biopsy only if there is a visual abnormal mucosa. In that way, we could identify 2 or 3 cases. Not everybody gets this, not everybody gets biopsy. It's only the high risk sector after visual inspection of the sinuses if the mucosa is abnormal. See, the problem here is few of the other colleagues, they try to biopsy even the normal mucosas. When you biopsy a normal mucosa, you can see the colonizer sitting there. You can just, a lot of times, just aspergillus can sit there and you can mistaken it. So this is other thing what we can do, and having a high threshold of suspicion to image and to biopsies if the patient develops symptoms. I think these are the 3 things which we need to do rather than prophylaxing everybody, or rather than imaging everybody. It's a case-to-case based approach is what I think is the need of the hour.
Very, very well said, sir. Really, it is how we should go forward. Ravicharan sir, he has been very instrumental in helping us out. Dr. Ravi, my question is, like, there are a lot of people who have a past history of chronic sinusitis or even asthma. We have been having known risk factors that everybody knows, that diabetes or hematopoietic stem cell transplantations or whatever. Are these two, like having a history of asthma and using an inhaler for a long term, or having a chronic sinusitis, in your experience, also a predisposing factor?
In my experience, whatever cases we got in the last 1.5 months, mostly were post-COVID patients who have recovered from COVID or who are suffering from COVID, and whose sugar levels are high, and who have taken steroids or who had a hospital stay. So chronic sinusitis, mucormycosis, my experience, I can only say, before this pandemic has started, yearly we used to get 1 or 2 cases of mucormycosis, where patient was a case of chronic sinusitis, where the sugar levels are high, so there is a stasis. So then that can cause mucormycosis in those patients. But asthma and chronic sinusitis, whether they are factors for mucormycosis, I don't think, and we don't have any data regarding that.
That is the message I wanted, that everybody should understand, that just having a history of chronic sinusitis probably is not a risk factor. And going now to Dr. Yash.
Can I just add one thing? Sampurna has done a very good presentation, but with nearly 30 cases, which I have done in the last 1 month, the whole thing is, the problem is the pterygopalatine fossa. So I think we have opened up the pterygopalatine fossa in 2 or 3 cases where the maxillary artery is totally thrombosed. And in 2 or 3 cases, though there is no erosion of the anterior or lateral wall of the maxillary sinus, the patient had a mucocutaneous mucormycosis. So we were just thinking what could be the cause. Then the answer I was trying to find, whether others have to add, was whether it is the infraorbital nerve, the third part of the maxillary artery, the infraorbital nerve, the descending palatine, and nerve of the artery of the pterygoid canal. Are these three arteries which are causing the spread and the thrombosis, necrosis of the and spread of mucormycosis? I just want others to add to it.
Can I add, sir, Dr. Rahul?
Yeah, please, please.
Yeah, I completely agree with this. And this is not only post-COVID mucor, in all mucor literature, it has been written that one of the favorite area to grow for mucor is the posterior wall of maxilla and pterygopalatine fossa. One of the reason can be the high fat content of the pterygopalatine fossa. The orbit also is full of fat, and pterygopalatine fossa has also fat. So in fat, the fungus can grow nicely, and it is the amphotericin B or whatever injection that doesn't reach well in the fatty area.
Very well said, sir. So, Dr. Yash, we have been having an enormous number of pregnant females coming with bad COVIDs. And unfortunately, some have developed mucormycosis in their second or in any other trimesters. Most of our experience has been with the second and the late second or early third trimester. So, as a critical care specialist, sir, have you seen pregnant females having mucormycosis, and how and what is your approach to such females? What medications do you use, and when do you advise them surgery, and what is your protocol?
Thank you, Dr. Rahul. Thanks for the question. Firstly, I'll answer. I haven't come across an obstetric critical care lady with COVID with mucormycosis, but yes, pregnancy is an immunosuppressed state and patients are at risk of infection. Hyperglycemia can occur in pregnancy. Pregnancy is like a physiological glucose tolerance test, we always say. So that could be one part. Hyperglycemia due to pregnancy, stress, COVID, steroids, everything contributing. Now, if I face such a situation, my treatment line will be same as for any other patient. The pregnant lady will get the due importance. If we do a risk benefit, obviously this is a very, very lethal disease, and unless it is treated, the outcome will be bad both for mother and as well as for fetus. So my line of treatment will be same: an early surgical consult, early debridement with liposomal amphotericin B 5 milligram per kilogram to start with straight away.
Thank you so much, sir. Dr. Manish. Hello, Dr. Manish.
Yeah, hi, Dr. Rahul.
Good evening here.
Good evening.
There is a talk about what Chakrabarti sir said about the way we handle the patients in the wards and the way there is the fungus going around all over Indian context, and mucormycosis is a given thing. If there is a given choice for the mucormycosis to be able to grow. So do you think there is a risk of healthcare associated mucormycosis apart from just the drugs, the steroids, or the mismanagement of, say, diabetes in a COVID patient? Is there any way other than these two that in the hospital the patient can still have a mucormycosis?
Yeah, Rahul, am I audible?
Yeah.
Yes.
Yeah, thank you, Rahul, and thank you, Ghanshyam, for inviting me for this discussion. Rahul, first of all, you have given me a very difficult question. So, after such a, a detailed, the description by Dr. Chakrabarti, I think most of the things are very, very clear for us that how the things are happening. If you ask me, Rahul, I think that, the mucor to some extent is definitely a healthcare associated infection. Let me tell you why. Because somewhere this infection, apart from, when we say that COVID itself is a risk factor, because of multiple, the plausible factors, which we still need to ascertain over the period of time. But yes, certainly, the exposure to immunosuppression has done the damage. So I will call yes to some extent, but saying, just because, although, everybody has said a lot about, the steroids, but I would like to differ, maybe the Ghanshyam will smile also, that, the steroids in our, the understanding have done more of a justice rather than, doing harm to the patient. Steroids, let me tell you, today morning I was, reviewing, one of the paper which was done by Rahul Pandit. This paper has, I think, published in Diabetic and Metabolic Journal. And they have studied over 5,000 cases in the last 15 months in the Fortis group of hospital, and not even a single case of mucor they have been able to demonstrate, despite of the use of steroids and all this stuff. I think calling a steroid or any immunosuppression as an independent risk factor would be too much. But yes, if you're using a steroid, definitely the responsibility of the healthcare provider goes on to maintain the glycemic control and all those kind of stuff, which we do understand. In case if it has not been done, then obviously it is going to be a risk factor. So in my experience, if you see the incidence of mucormycosis, I'm seeing 3 of the hospitals right now, and not more than 20-25 cases in comparison, in proportion to the pandemic which we have seen. Still the number of cases has been significantly less. And India per se, maybe Dr. Chakrabarti can correct me in case if I'm wrong, India has always been known as the capital of the mucormycosis. So it's not something which has happened just now. It was always there because of multiple risk factors. But yes, the COVID has done the damage.
Rahul, just want to add. Manish, I don't think, I think all of us agree that, steroids independently probably may not be the cause. I think it's the steroid-induced hyperglycemia and the poor glycemic control, which probably is the major culprit.
I think, Ghanshyam, you are very much right. In fact, as Dr. Chakrabarti and Vishnu, both of them has clearly said that, the steroids, I think it's more of not the steroid which has done the damage. It's basically the improper handling of the steroids, especially, when the people are using, the rescue doses, and they're not taking a responsibility for the hyperglycemia and all. So in majority of the cases which are received, the rescue doses of steroids in our settings, these patients, they have been having some kind of a glycemic control protocols.
So just taking that question forward, I would like to get the input from Dr. Vishnu.
One thing.
Yeah, please.
That the steroid also has some role, I think, Dr. Manish, because it is just like what diabetes does something that is a risk factor for mucormycosis. Steroid also decreases the macrophage activation, and it also causes neutrophilic chemotactic factor to decrease. And there is certainly, to some extent, I would not say short course steroid or steroid given at the doses that we have been already arguing about for the last 6 to 7 sessions now. It is definitely, there is some role of steroids given for a very long time, for a very long
I understand, Rahul.
I think Dr. Chakrabarti wanted to add something.
If you just give me a minute to explain, Rahul, see, I'm not saying that, the steroid has not done the damage, but we need to understand the steroid has been used for multiple reasons in the transplant setting, in the patient rheumatology, for, the pulses. The steroid has been used for ages. It's not something which we are using.
We are talking about not something, here in COVID. COVID per se, if I am not right or wrong, COVID per se, I'm very, very sure.
Yes, I agree.
In one way or the other, I don't know, the mechanism is causing the body's milieu to be very, very conducive for mucormycosis.
I can come here, Ghanshyam and Dr. Manish, if I can come here.
Yeah, please.
I would say that yes, steroid has been used in so many other diseases. This question I've faced several times. Have you used 30 milligram Dexa ever? That means more than 200 milligram prednisolone. Have you used that much of doses anytime? And for a month, this happened. I'm not blaming the doctors. When I have looked into the narration of all the doctors, what happened, there were several protocols out there which had said you give for 5 days 21 milligram Dexa, and then you shorten down for a week. That is the triggering factor. If you are going up to, say, suppose 6 milligram or 40 milligram prednisolone, that's normally given in many of the disease. And of course, glycemic control is also being done. But have you heard ever that the blood sugar has gone 800 milligram? So I'm saying you, this is up to, yes, steroids save a lot of people. Steroids save a lot of people in case of COVID, especially who are in case of the ICU, and that had really helped. But possibly in case when there is this oxygen crisis was there, when people are not getting oxygen, waiting for 2 hours after that oxygen is coming. So they went on increasing the steroid. That was the major factor which was there. I would say that why it had coming down. If you see both in case of the Maharashtra and Gujarat, where the maximum number of cases, the cases are coming down. Why? You tell me. One major factor, now people are using steroid with a prescribed limit. That was the major thing happening, and of course, glycemic control is also being taken care. So steroid, I would not say, I am not going to blame any doctor. This was a crisis happened. That's the time when it had slowly the cases are going down because of that. And the question which you asked about the healthcare associated mucormycosis, that's a completely different thing. You know, healthcare associated means we used to know this used to happen mainly in case of the people having got armrests, which is getting contaminated, cutaneous mucormycosis. A lot of babies suffered, especially in the intravenous site, which is remaining for a long time, that is there. But in case of India, the problem of your healthcare associate is also getting from the air conditioning duct. Have anybody have surveyed about your air conditioning duct? Do you have HEPA filter in your ICU? All these air conditioning ducts are full of mucor and aspergillus. Because of this non-cleaning, especially whenever you have got a central air conditioning facility, if you are not doing 6 monthly robotic cleaning, then it's there. It is there, and that's the major source of both aspergillus and mucor in our environment. We cannot afford to have HEPA filter. That is every 6 months you have to change. And such a big ICU, how many HEPA filter you require? You are doing it in case of bone marrow transplant where there is HEPA filter, but you cannot have in case of ICUs. Because of the costs, that is the major issue which is there. So if you are not doing all those things, if you are not doing this aspect, India has got a different type of hospital acquired mucormycosis, which is not in the rest part of the world. They don't see such type of mucormycosis from the environment and going into the respiratory tract. That's why we are getting also pulmonary mucormycosis quite high in number.
Ravichandran sir.
No, I had a question. There were 2 patients who were post-COVID, home quarantine, oxygen not taken, steroids not taken, but mucor positive. And when we check their sugars, it was above 300. So what was causing that?
Sugar.
So where any mutation is the cause,
No.
or is there any other cause?
Sugar.
So we have been seeing a lot of new onset
hyperglycemia,
but not a known diabetic.
Yeah, many a times, even in non-COVID era, patients have come with mucormycosis and diagnosis of diabetes, and DK was made for the first time. And there are cases of euglycemic decay also, which we have come across. Any opportunistic infection, we need degree of immunosuppression and duration of immunosuppression. With COVID, we had both. We had a degree of immunosuppression, which was precipitated by steroids and diabetes, and the duration. Now, who all were wrong? Many doctors were wrong, yes. Many patients have been self-treating. I saw prescription, the patient was prescribed for 3 days and he has been taking for 15 days. And an educated patient. Many quacks, many medications which are available over the counter. I will not say what type of medication, but they have steroids. Patients have been taking some medications and we don't know what is the ingredient of all those medications. So the problem had multiple folds to it, and probably each fold has been exposed gradually. One question I wanted to ask Arun Alokhe sir. Sir, monocyte and macrophage dysfunction, which is there in diabetes also. And COVID also had monocytopenia and some other lineages were also decreased. Could it be one of the contributing factors like?
I said that how COVID is playing the role, we are not very clear yet. I said that when people ask me, I am not satisfied by giving this diabetes and steroid. I have still see the amount of cases, see the prolific growth, and even from the nose it is like coming out. Such amount of growth, something is there with the COVID, which I am still studying. I am not thinking that COVID really is above. And now you can say, yes, COVID is always there in throughout the world. Why it is in India? That's why I'm looking into how combination played here. That is the major issue which we need to, and whether the variant, the Delta variant we are studying, that whether this Delta variant has got some more role to play in case of disturbance of monocyte and this neutrophil. So these are the questions which see, the thing is that don't think that I have all the answers. I've got many questions in my mind. So I'm trying to really trying to find out the answer to those questions.
Sir, if I may add with our with our data from our institute, I mean, definitely, in the beginning, we used to see a lot of these uncontrolled sugars and diabetics getting mucus. Even the first wave after that, we have seen now also. See, now, for example, we have few patients where the cumulative dose of steroids is very, very low. I have a patient now who is never a diabetic, HbA1c normal, young male, 2 doses of steroid came with mucus. So we are looking this kind of thing. Even if we see the last few days, the cumulative dose of steroids, what they've taken is very, very low. It's not even equal to, some total 300 or 400 mg of prednisolone over the course of 10 days, non-diabetics. We felt that this is a lower cumulative dose of steroid for somebody to get mucus. So I thought I look into the literature because we're seeing this more and more. So one of the plausible explanation which has been given in certain papers is that about this, this GRP78, I was told that, a diabetic, somebody with uncontrolled diabetics, somebody with diabetic ketoacidosis, and somebody who is being given steroids, this GRP78 expression goes up. Actually, along with this new Delta variant, it not only uses the ACE inhibitor, it also uses this GRP78 variant. So one of the plausible theories that have come is that COVID per se is causing increased expression of this GRP78, which is also a receptor for mucus to increase action. So there is something else. These are certain plausible explanations giving in the theories and papers, but definitely it is appearing more and more sure that it's not only the diabetes and the sugars. Yes, COVID has something to do with it. We don't know still what it is. It's been increasingly evidenced by the fact that very minimal dose of steroids in the absence of diabetes with normal HbA1c, young people are also getting mucus. We have increasingly seen those accumulating all this data, but yes, that is the unanswered question which has to be answered. Yeah.
Vishnu, this GRP78 is in the endothelial cells. This is getting upregulated. This has happened because of the endothelitis, one issue, which is by by COVID itself causing the endothelitis. If you see up the 2 autopsy series which have been published in case of the New England Journal of Medicine, both of these series had shown the amount of microvessels damage is much higher than even in influenza, which have been shown very clearly. And they have shown that this GRP78 going up. And this GRP78, you are very right, also helping COVID, causing the COVID itself can cause also increases the GRP78. Hyperglycemia increases, also COVID can increase. Yes. So you are very right in that perspective. And that is GRP78 where cottage, which is the receptor on the mucor, that gets adherent. Yes. And because of that, mucor can get the entry inside the blood vessel, smaller blood vessel. They interfase, then they produce the thrombi. That is the way they go ahead with.
But it's very surprising, sir. Very surprising. I mean, all these days, like young males, 5 days of minimal dose of steroids coming with mucus is very, very frustrating to see. Looking into taking all the reports, seeing if he's been pulsed, nothing has been given, no sugar, HbA1c is normal. Coming, these are the increasing cases we are seeing. We need to find out, sir. I mean, you're from the research center.
Sampurna, you wanted to say something?
Can I ask? One question, sir, that in one paper about aspergillosis, I read not one, couple of papers, they wrote that there is some toll receptor and interleukin 10 genes modification, which makes a person more susceptible for aspergillus. So maybe something like that is there in mucor patients also or not, we should think. And I always thought why few of the states in India got affected. If you see the data from, if I ask my Kolkata colleagues or somebody in Assam, Mizoram, they are not getting mucor cases at all. So is it some the genetic factor of the people itself or the geographical ecology is the mucor more in the air?
See, the thing is that people have not looked into it. Like suppose when I asked in case of the West Bengal at the beginning, from Dr. Suva's story onwards, everybody said there is no mucormycosis. Now they have got almost 76 cases. So again in Assam, I am going to take a presentation on day after tomorrow in Assam. I'm trying to educate that situation. You know, like suppose if you don't see those cases, you don't think about there is a patient which is having mucormycosis. But one important thing I like to tell you also, please look into this issue. It's not only mucor, 5% of our cases is the mixture of mucor and aspergillus. That is happening. And that's very interesting. And even in case of our pulmonary mucor, we are seeing associated kappa is there, COVID-associated pulmonary aspergillosis. So, yes, Vishnu, you are right. Something is there with the COVID, which we need to study, which is really determining immune suppression. But this immune suppression is not a very general immune suppression. Otherwise, why not we are getting higher bacterial infection? We are not getting higher bacterial infection. It is, we are seeing much higher, that is in case of mucor and aspergillus. And this is linked definitely with the macrophages. You know, macrophage and neutrophil are the innate immunity, because if you see that they are also doing, if you see the first Yuan paper from China, they have shown that the T cell gets disturbed. T cell disturbance has no role to play in case of mucor or aspergillus. That is playing in case of histoplasma, in case of our cryptococcus. It is not at all a major important factor in mucor and this aspergillus. But they initially showed that there is T cell disturbance. But now when we have looked into, especially the paper which is coming, 2 papers which have come, it's showing that there is the immune dysregulation which is having post-COVID period. So we need to have, we will give you answer very soon, because we are doing this transcriptomic study. We are trying this. These are, till I have the answer, I am not very happy. We are looking into this aspect.
Thank you, sir. Dr. Yash.
Yeah. Dr. Rahul, I will let's add on another point, healthcare associated mucormycosis. See, we were seeing healthcare associated mucormycosis earlier also. I remember 10 years back, we had a case, chemotherapy leakage caused skin and soft tissue infection from the chemo port. And then we did a biopsy and found mucormycosis. And surgical site, there has been reports of mucormycosis earlier also. Cutaneous mucormycosis in burns patient. These are the healthcare associated infections. Wooden spatula has been attributed. We had a case of intestinal mucormycosis. We found all the reasons. We could not find any reason. And then there was a history of oral examination with a wooden spatula, but that also was a speculation also only. So the likelihood of healthcare exposure adding to risk is also very, very putative.
So my question to Dr. Yash is that, sir, how do you proceed for diagnosing a patient? Now that you have a COVID patient, you see that there are certain signs and symptoms, predisposing factors. So what is the way you actually approach the patient? Do you immediately get a CT or an MRI, or you post the patient directly for a say as a sinus exploration? What is, and then what is the role of your KOH or tissue biopsy?
I will keep it very, very simple what we do.
That is what we want.
See, pulmonary mucormycosis, generally we will diagnose, we did not go for help. Generally we do a HRCT, things are quite obvious. The only problem is differentiate between aspergillus and mucor. Bronchoscopy, we rarely go for bronchoscopy, but a deep sample through a double lumen catheter generally solves the purpose at times, or galactomannan report negative, then we'll likelihood of mucor. Otherwise, we'll give a common coverage for both until we have a certain diagnosis. If we go talk about rhinocerebral mucormycosis, the first thing, if we suspect it, we call the specialist. This is our dictum. We will not try to indulge. Then as per their advice, we'll either go for a contrast CT or a contrast MRI, whatever they feel like. Because many patients just come to OPD to, they are having some sinusitis, might be bacterial. We cannot go for MRI or contrast or scopy for each and every patient. So we refer to them. But unless they do an imaging or a scopy, we are also not very, very sure that they have ruled out with certainty mucormycosis or sinusitis only for that matter. Second question is about the specimen. Scrapings, if we generally do not go for scrapings, the diagnosis will be very, very uncertain unless it is a very, very clear cut. Some rhinocerebellar mucormycosis are spot diagnosis. Like if the patient is in your room, it's like an elephant in the room. You have to diagnose it. You cannot miss it. For difficult to diagnose cases and for documentation sake, we have to have biopsy and we go for tissue diagnosis. KOH stain is one among them, and invasiveness has to be documented in the tissue specimens.
Thank you, sir. So taking this question forward to Dr. Abhicharan, sir, we have a patient who is having all the predisposing factor of having a mucormycosis. The CT scan shows that there is sinusitis. Then you go in and then you see a normal mucosa. Where is the point where you try to really find out where the mucor is hiding? This is for the benefit of our ENT listeners. Where, what is your take as an ENT senior specialist to where to go to get it?
No, the thing is nowadays, whenever we are getting many patients who, because of this press exposure of mucor, they are coming to us saying that, sir, we have headache. Then we take a CT scan. Usually we see it is normal or there is a very mild thickening of the maxillary mucosa. So we explain to the patient that it may not be mucor, but if you want, we can go in and we can see. There we post them for endoscopy or FES, and we open up the maxillary sinus, see what is there inside, and send the tissue for fungal staining and histopathology.
Where do you think that it is the most common we should take out? Is it that just the mucosa which is looking little fishy, or you go into somewhere deeper inside?
No. See, most of the time in mucormycosis, you find a scab of tissue on the middle turbinate, but that we are not seeing nowadays. So when we open up the maxillary sinus, we see whether the mucosa is normal or any abnormal mucosa is there. If there is any abnormal mucosa, we collect that abnormal mucosa and then send it for test.
Rahul, just want to ask Dr. Vishnu, when it comes to intensive care patients, see a patient coming with probably a sinus or orbital or rhinocerebral, sometimes very evident, most of them come to the OPDs. But in an intensive care unit patient who is on the ventilator, when would you suspect and how would you proceed?
Yeah, I mean, if it is a rhino orbitocerebral, it's like very much evident. When it comes to the pulmonary mucus, number one is, what are the type of lesions we are seeing? For example, our data, the pulmonary mucus, whatever the post-COVID cavitary pneumonias, whatever we have, majority of them are turned out to be mucus. Number one, mucor we have. Number two, aspergillus. Number three, nocardia. Number four, TB. These are the top four post-COVID cavitary pneumonias. But if we have, for example, say sampling is an issue, say, when would I suspect? When somebody has cavity, when somebody has a reverse halo sign. This is something which characteristically with the presence of which will help. But we always try to go for a sampling as much as possible because we have good intensive, good pulmonologists who can do the tissues, cryobiopsies and all. So always the best way to get a diagnosis is the tissue. But if the patient is very sick, tissue is not possible, but we have a cavitary pneumonias post-COVID, we try to cover aspergillus and mucor because these are the two common what we have in our setting here. And if it comes to the, sinus, it is very easy. The ENT, if it's very much evident, if the patient has come to IC with a mucor here means it's already must be going into the cerebral. So it is very easy for the ENT to do a bedside tissue and give it to us. So that's how we diagnose. Yeah. And when we think of mucor, we start on amphotericin B. We don't wait. We start it and we parallelly investigate because delay, just like in sepsis, delay in administration of antibiotic increases the mortality. Once you have a clinical suspicion of mucor, start amphotericin B, do the workup parallelly.
Professor Chakravarti.
Yeah.
Sir.
Ghanshyam, I have a question for Sir Dr. Chakravarti. Sir, suppose we take a deep ET aspirate, not a superficial one, we pass a long catheter and take a deep ET aspirate, which shows evidence of mucor. How should we take that report?
See, the thing is that in case of any, between aspergillus and mucor, I put in that aspergillus still can colonize. mucor is hardly any colonizing in case of the respiratory tract or anywhere. Mucor is more of a outside from which it is coming. Aspergillus still colonizes in the upper respiratory tract. It has been seen. That's why in case of immunocompetent patient, it is difficult to distinguish whether it is colonizing or invasive. If you are seeing in case of ET aspirate or anywhere the mucor is there, suspect most likely it is an invasive mucor or a colonizing mucor inside a cavity. That is very clearly we have seen that mucor generally don't go and colonize this area.
Sir, just taking that question a little further, Professor Dr. Chakravarti, how do you see the role of PCR in the diagnosis of mucor? And if at all there is any such role, what would be samples?
I'm not sure why so many people are missing in case of the simple KOH. This is the first time, generally we say that it takes, some people are missing. Our 90% of the cases, in the first KOH, our senior residents are picking up mucor. 90% of cases, but a lot of people saying there is mucor growth in culture, but they are not seeing in microscopy. I feel that there is a bit gap in case of training must be there. I suggested in different type of state committee, the state task force, that possibly you can bring on microbiologists in a particular center where it's more developed, so that all within a day or 2 days can be trained on this aspect. Because a lot of things depend on it. If you can, like suppose if you can see in KOH, within 30 minutes you are giving the report. And if you are not seeing it, then the confusion starts in the clinician's mind. What should be done? What should be done in this aspect? So I feel that is there. Now, PCR only can help if it is a sterile sample. If it is a non-sterile sample, like suppose nasal swab or nasal aspirate, you can have one spore. One spore can give a positive report. So, and these spores are so much in our environment. So mucor PCR only in sterile sample. Also, in case of biopsy, sometimes it happens there is a fragment of hyphae is there, which cannot delineate whether it is aspergillus or mucor. We have extracted the DNA, did the sequencing, and help in case of identification. So these are the role where it can be used. And there is a kit available from Netherlands, which is using in case of the PCR for mucor in the blood, which we have seen not so sensitive enough. At least we are not finding it sensitive. We are asking other people to use it. They are also saying, sir, no, we are not getting this. So it's a bit disturbing. We need some procedure so that we can give you a diagnosis quicker. There is nothing in there in case of mucor. But I don't encourage that your KOH is failing. That's why you please do the PCR. That's the wrong concept. Rather, you send your microbiologist to a place like if you are in, every state has got at least one specialized center where you can send the people and they can just 1 day and 2 days training is sufficient. It should not have a problem. But at least in our center, we are not missing any case in that sense. We are giving the report within half an hour. And they don't call me for looking at it. They are very confident. Sir, this is absolutely, and both is there, aspergillus, mucor. I said, look, it is mucor. How you are saying aspergillus is also there. Sir, you please look into it. There would be. Yes, I found there is aspergillus. So I say that this needs some training, nothing else.
Dr. Vishnu, there has been a talk that statins have some role about, in fact, both prophylaxis as well as treatment because of certain help that it does to prevent as well as kill the fungal infections, specifically mucormycosis.
For mucor, what works is debridement, amphotericin B, posaconazole, isavuconazole. These are the proven treatments. Neither the desferoxamine, nor the desferox, nor the hyperbaric oxygen, nor the statins. There is no proven role. It's been debatable. We never use statins or any of this for treatment of mucor. Few have, there are few case reports of desferox being used, but as a standard, majority of the recommendations doesn't. And I also personally believe is the debridement, amphotericin B, step down posaconazole or isoconazole. These are the things which will help.
Right.
I want Dr. Arunlok to speak on this. What does he think?
Vishnu, in case of the statin, it is the Dimitrios Pontianis, who is the MD Anderson person. He has got the paper, who has raised first time this question. And he said that in USA, the mucormycosis rate has fallen in case of the diabetes because of statin use. So then the statin, Dimitrios type of person says something, and it is published in CID, Clinical Infectious Disease Journal. So you can imagine that what was the impact. You are very right. At least I also raised Dimitrios. Look, we are using statin in case of diabetes quite frequently. It's not our patients are not given statin. We have given statin much more possibly rather than USA people. And we don't have any role in case of statin. But I would say that deferoxerox has possibly some important role. This has been damaged by the people in case of the Stanford when they have studied this particular defeat study. Because in case of animal model, it was very clearly shown with amphotericin B combination, it has got definite role is there. But that particular defeat study has defeated this deferoxerox. Rajiv Suman has used it and published 7 cases in case of good journal. I still feel when there was no drug available, please use deferoxerox. When there is no drug available. I'm not saying that, don't quote me anywhere that I've said deferoxerox is the mode of treatment, because still evidence is lagging. This way, like suppose from fungal infection study forum, at the very beginning when there was no drug available, now a bit eased out, I would say, because people are getting some amount of drug. Of course, amphotericin B is controlled by government, and there is a crisis still, but people are getting isavuconazole or posaconazole. But in case of when there was the crisis, we even recommended itraconazole.
Yeah.
Itraconazole we recommended on the basis of our in vitro data, our this epidemiological cutoff value data. I discussed with my European friends as well as my MSG mycosis study group, all the people. I showed all the data. I said, can I not recommend this particular, because I wanted some support of recommending nationally itraconazole to be used, because it had never been, only few case reports are there. But then some of the people have used itraconazole. I'm trying to collect the data of those people who have used itraconazole. But now things are getting a bit eased up, so people are using it much less. Similarly, we say deferoxerox when nothing is there. Shall we say that we will not give you anything? Try with something. So that was the last resort. But I still feel deferoxerox needs study.
Just one question to Dr. Vishnu and to the rest of the panelists. Yeah. With respect to the dosing of amphotericin B, now there have been a couple of recommendations, even the recent guidelines suggesting to use a dose as high as 10 milligrams per kg, yes, 5 to 10 milligrams. Yeah. Now, does the site of mucor make a difference with respect to the dosage? Second, if there is a renal dysfunction associated, then how do you go about it?
Yeah. See, first thing is, I have only used in one patient 10 mg per patient till date. The indications quoted are, number 1, if you have a cerebral extension of the mucormycosis, number 1. Number 2, if you are using in a disseminated case in a solid organ transplant. Number 3, if there is a disseminated disease. These are the indications where you can use 10 mg per kg. But the problem is that, only one patient with pulmonary mucor disseminated, we could use it. Few of 1 or 2 other patients we tried, but it's severely limited by the toxicities. So next, so only one patient and cerebral, and now we had one patient with cerebral extension despite giving on 2 drugs, despite good debridement. I cannot give now 10 mg per kg because there is no drug available. Is getting 5 mg per kg itself is a big issue now. So we are just giving and waiting and watching. And coming to the amphotericin being the nephrotoxicity, if it decides on a case by case basis. I don't have a specific cutoff. If there is a rapid rise of serum creatinine, if the doubling is there, very rapidly, then I will hold the drug till the creatinine gets better. Then I'll give the full dose. And say if the patient has very bad disease where I have to give the drug, I cannot stop the drug. At times I reduce the dose and give it. But this is not because it's a case by case decision making. There is no 100%. Ideally, the recommendation says if the creatinine goes up, stop the drug and reintroduce. But that is not always possible because of the extensive nature of the disease. We still give it. Probably we'll give it a reduced dose. We'll again check the creatinine. We'll try to do as high upper end of the normal limit as possible, maintaining the serum creatinine.
I will add about the dose. See, only rhinocerebral, it goes up to 10 to 15, otherwise 5 milligram per kilogram. Another important thing about dose is you do not gradually build up the dose, because some people are still doing it sadly after years of teaching. You have to give the loading dose directly, and even if there is some organ dysfunction, the loading dose should go in, and then the follow-up dose could be modified according to the renal parameters. So the dose is 5 milligram per kilogram for rhinocerebral or for pulmonary mucormycosis. If it is cerebral, then 10 to 15 milligram per kilogram.
Yes, just extending the discussion a little further. In the absence of, as Dr. Vishnu also said, now we are facing a severe shortage of liposomal amphotericin B, right? And probably it's much more easier to get a conventional, right? So can that be used?
Yes,
right? Especially because again, isobuconazole is very expensive. IV formulation and availability is a major issue.
My confidence would be more with any of the amphotericins than for posaconazole. Isobuconazole, the availability is very, very scant, and very few centers have the luxury of affording. So if you don't have liposomal preparations, there are other preparations. There is lipid complex, there is colloid dispersion, and there is conventional amphotericin B. Conventional, before this pandemic also we have to use at times because of severe cost constraints, we have to use conventional amphotericin. And remember, the efficacy is same, only the dosage could be better placed, and the tolerance of dosage is better with liposomal than with conventional. With conventional amphotericins, renal tubular acidosis, hypokalemia, renal dysfunction, all these are much higher. So the acceptance and the compliance with the dose becomes an issue in the long run, and looking at renal dysfunction or acidosis, often we have to discontinue and then switch over to liposomal preparations.
Dr. Vishnu,
yes,
with respect to the availability of posaconazole, either in the syrup form and the tablet form, right? There are the two formulations which are available. And what would you recommend and why?
Yes, sir. In the tablet form, sir, we have two things. One is a delayed release. The other one is a gastro-resistant. And the third one is syrup. Number one is we always prefer tablets over the syrup, because syrup, there is absorption issues is a problem. And we need to check the therapeutic levels. In our state, therapeutic levels getting is very, very difficult because only few centers do it. And when you give syrup, you have to clearly tell to the patient that we have to give it with either ghee or butter or cola drink. This we have to insist. In fact, patient loves when I say you have to take it with Coca-Cola. But these are the three things, make sure that. But now that we have tablet formulation available, we should prefer tablets. Tablets has a better absorption mechanism. And we have in this delayed release tablet, the tolerance is less. Patients are getting more side effect, but it has a predictable therapeutic levels achievement. Whereas the gastro-resistant, it has lesser therapeutic value achievement, but more tolerance. So these are the pros and cons. But currently in the state we are just like, please take whatever is available. If you don't available syrup, tablets, you take syrup, make sure that you take with this. And if possible, we are checking the trough levels. And for treatment, we are targeting 1 mg per liter is the targeted trough level for a therapeutic response. If I'm giving you a prophylaxis, it's 0.7 for treatment, 1 mg per liter. So always tablets I would prefer. If tablets is also not available, then whatever is available, make sure that he takes with the ghee and check the trough levels if we have to give syrup.
Yeah, before I give Rahul to conclude, just one last question to all of them. How do you decide the duration?
Yes, sir. It's a very good question, sir. There is no recommendation, there is no clear-cut recommendations on how long to give. For example, for aspergillus, minimum 6 weeks till complete clinical and radiological resolution is the treatment for aspergillosis. When it comes to mucormycosis, the treatment is till complete clinical and radiological resolution. What we really do, we try to give 4 to 6 weeks of IV amphotericin B, and then every week we do visual inspection of the sinuses. Probably we image after a month and make sure that when the ENT surgeon and when the ophthalm or when the IDB all convinced that disease is fine, well under control, then we shift to the tablet posaconazole. We give somewhere between 6 weeks to 6 months based on the this one. But now what standardly we are doing, because of the absence of drug, is if it is only in the sinus and nothing elsewhere, we are at least try to give 2 weeks of amphotericin, good debridement, 2 weeks of amphotericin, then shift to the tablet, give it for 3 months. Say when it is going to extensive mandibular involvement, at least 4 weeks we are trying to, where they have to give even mandibulectomy, 4 weeks minimum we are trying to give. And then switch over to the tablet posaconazole. Somebody has eye involvement also, 4 to 6 weeks. Brain involvement, 6 to 8 weeks. So in gross, whatever, the best, whatever we are available, this is what we are currently doing.
And one more last question. Yes, combination versus mono.
In this time when we have severe scarcity, we will not go for combination. Otherwise, also combination has very few indications. A very deep-seated infections where you cannot do source control, and where resistance has been documented. So these are two subsets where you have to go for combination. Otherwise, combinations are not required.
Vishnu,
it's an overkill.
Yes,
it's an overkill.
Yes, sir. Before also, sir, I am not a pro for a combination. If I could do a good debridement on ampho-B followed by POSA, if you have a disseminated disease everywhere, or where there is an area where I cannot debride, if it's in the lung and it's involving the multiple lobes, I cannot debride or cannot cut out the lung. So probably those are the patients. Probably I may.
Suppose I have a renal dysfunction where I'm cutting down on the dose of the amphotericin B, right? Would
yes,
you
sir.
add on something else?
Yes, sir. I think it's a case-by-case discussion, a case-by-case decision. I think you can very well. When you're not comfortable, for example, this is what I'm doing currently, sir. Now that ampho-B, one day patient is getting, one day patient is not getting. So I'm putting the patient on posaconazole from day one and trying to give ampho-B how many ever dose he is getting. At least you'll get one drug for sure. The ampho-B, I'm not relying. One day emulsion, one day patient is not getting. This is what is happening now.
Rahul, over to you.
Thank you. Thank you really so much, Dr. Sampurna, to present the difficult topic in a very interesting way, to take us to the journey of the patient coming to the clinic, to how to diagnose, to how to treat, and what are the complications in the way that we will be seeing. And thank you all the speakers for actually touching points that are very sore to debate and very difficult to say comprehend and explain also. So what we have understood is that mucormycosis is there, and it's a real problem, that the problem is beyond our control, in the sense that it is there everywhere. That also, with the scarcity of the resources we are having to face, there are challenges to treat such patients. There is a silver lining that we know that there are a subset of such patients who are at the higher risk, and high index of suspicion is no longer the norm. We are suspicious about everybody nowadays. So being on the back foot and taking a early decision of starting a antifungal therapy and going more aggressive on surgeries and sticking to the protocol, whatever has been given in the guidelines, is the best foot that we can take forward. Thank you so much, all the speakers, Dr. Vishnu, Dr. Yash, my dear Dr. Ravicharan sir, Dr. Manish, and of course, the Dr. Chakravarti sir. Thank you so much for such a healthy discussion.
Thank you, everybody. Thank you.